Hey, so it's Wednesday. Welcome to the home edition of I Want to Be an EMS Professional. We're going to look at the medical overview, which is actually chapter 14. This will greatly benefit you if you can have your medical assessment sheet available. Just as we go through those points, I think it makes better sense where you can actually see why we're doing this information, put it into the context, oh yeah, this is my patient assessment. It's a lot of information I know you've seen from Bridget on some of the Saturday classes, but with this, what we're actually able to do is go through, look at the different conditions that people potentially suffer from, get some more information on definitions such as NOI, tacos, sample, right? A lot of things that fall within that evaluation sheet and skill. So what is the medical overview, right? EMS assistance, traumatic emergency, could be a medical emergency, and it could even be both. And so I was looking through this thinking, well, what's both? Well, how about someone who has a history of anaphylaxis and is driving in their car, windows down, it's nice out, and they get stung by a bee. And then as they react to that, they potentially crash into a tree. So again, that combination of medical and trauma can certainly happen. When it comes to the skill sheet or that patient assessment, that is not something that we're going to throw in at test time. It is something that if we were together and we're practicing skills, yeah, we want to give you those critical thinking capabilities to make those proper decisions. But right now, we're just going to focus solely on the medical side of things. Coming out of the Mod 5 from trauma, hopefully everybody's pretty comfortable with that. Obviously, we'll be reviewing that more as we move forward. But, and I should say before I get even further into this with the specific types of medical emergencies, very important date, and that is September 18th, 1884. Keep that date in mind. So types of medical emergencies, again, this can be breathing, it could be cardiovascular, neurologic, something like a stroke. But when you look down at the secondary assessment, that's where these things come in. Oh, it's a GI, integumentary, deals with the skin, musculoskeletal. So there's only, 8 listed. We've got 4 on this page. We've got another 3, so that's the 7, the endocrine, dealing down with immunologic diseases. Anaphylaxis would fall into that. 7, 8, 9, 10. So there's more to include on that potential what type of medical emergency this is. Some of those could be, toxicological emergencies, or there's an overdose, get down into the psych or behavioral issues, gynecological emergencies. Is this a pregnancy? Is this an ectopic pregnancy, right? Those are all some of the questions you're just going to be asking yourself. So on the patient assessment, and I know we focus on NOI symptoms and chief complaint, but keep in mind, these are why we give you these skill sheets early. How am I still going to start any assessment? I'm going to say, hey, my PPE is on. I'm going to ask the evaluator, is my scene safe? You receive call-out information, and that should steer you in the direction of a mechanism of injury, or in this case, nature of illness. And then we can continue down. We still need to consider C-spine, need to know how many patients I have. And when you get to the point of asking about C-spine on a medical patient, even though it may come in your call-out, you respond to a 6-year-old male sitting on his porch having a hard time breathing, just ask, right? Think of it as a rule-out criteria. Hey, sir, did you fall at all today? No, I did not. Great. Now you know that C-spine's taken care of. But just to assume because it's a medical patient can lead you down a slippery slope, if you will. So we'll continue on with getting the medical history. And this comes up a little further on. We start thinking about some of the mnemonics that are associated with a medical condition, the sample, tacos, paste, opcursed eye. I mean, there's a lot of these that actually do come up. So we'll run through those as well. But getting a medical history, that's what first happens in your call out, right? This is that 60-year-old male that's complaining of difficulty breathing. Don't get into this preconceived notion either. Yeah, someone's having a hard time breathing, but what can be one of the causes of that? is this heart failure? Oh yeah, it's a left-sided heart failure. And the person's pretty sedentary to begin with, so they haven't really noticed that. But the CHF, or congestive heart failure, indicative of that left-sided heart failure, could be something else. So again, don't think it's just that one thing. This is why we investigate, and it's so important that you critical think through these calls and potentially what's going on with your patient. If there is an injury, and this kind of combines medical with trauma as well, but something as simple as a slip or a trip happens, and when that's in a, I want to use the right term, I don't want to say just geriatric patient, but why does someone fall? You know, did they trip over something, or was it a cardiac related issue, some new onset of AFib, something that interrupts that blood flow to the brain, and that's why they fell? So always make sure you check the surroundings. Kind of leads into the GEMS diamond, but it doesn't specifically have to be just for an elderly patient. So that's why we don't want that to kind of just suck in. Oh, hey, you fell, you hurt your knee, but do a little more investigative work on assessments. And as far as your patient being difficult or hostile, again, I'll have to comment on this. I mean, a professional, calm, non-judgmental demeanor, that's done for any and all patients, you know, not just the uncooperative or the hostile, or potentially even the combative patient. For that, of course, we're going to withdraw. We're going to have the appropriate law enforcement respond to that. But labeling your patients, right? Something you cannot do. And when we look down, the frequent caller has different complaints this time. You know, I will just say that some responders learn this the hard way. And you know, pretty upsetting example of this is you respond to the home. The guy's got a history of, you know, alcoholism. The crew that responds has picked this person up, put him back in bed, you know, a dozen times, and they show up, and there's a loved one waiting at the door, and the crew actually says, "So, how drunk is he this time?" And you know, the person's face is obviously now turning ashen, points over to the room, and the gentleman had actually coded during the night. There's rigor mortis, there's lividity on the patient. So just think about that experience and how that affects, you know, primarily that person who is still there with the patient. But that should also have an effect on you as a potential responder, right? That's not the type of behavior we are looking to emulate or create in this profession. So this is a good opportunity. Look at your sheet, start thinking where these steps come in, right? Scene safety, we're always concerned with that. We have the appropriate PPE on, but then we're also asking, how many patients do I have? And the number of patients is kind of a preview for what's coming up. If you have multiple patients complaining of the same, you know, symptoms, they all have difficulty breathing, they're in this one building together, fresh air setting, right? Is that environment causing this issue? And again, that's just something you clue into when you see multiple people complaining of the same illness or injury now. So nature of illness, we think about index of suspicion. Index of suspicion helps you kind of predict what's going on with that patient. You're someone who is stable. Can they eventually turn unstable? Well, absolutely. So that's just something, even though it may look like we fixed it initially, that's why there's a reassessment, right? We always go back, we reassess our patient, make sure everything is okay. Because they could be good for a couple of minutes after you gave them a breathing treatment, and then 7-8 minutes later, they're returning to those how they were before you gave them the medication. So your general impression, okay, there's a bee in my garage, so excuse me, I think I took care of it. I do have several epinephrine pens just in case. So, but when we develop that general impression, a couple of ways to think about this. And your text example, a rapid examination of the patient, sure. Quickly determine the patient's level of consciousness. Well, how are you going to do that? Well, this is where you say, hey, my name's Brandy, I'm a paramedic. What's going on today? Can you tell me what's happening? And when they can explain fully to you, what does that mean about their airway? So yeah, it's patent airway, it's intact. Or there could be this 2 or 3 word dyspnea, hey, it goes along with the difficulty of breathing. But your general impression, and we combine a lot of these things, is that, oh, I'm going to look. I'll give you an example. Difficulty breathing patient. General impression of that, Well, aside from being a fantastic actor for you, is you could see that that patient is struggling to breathe, right? We see the tripod position. Give you the same type of call. Here's a patient complaining of difficulty breathing. I've had this call. They're at the casino. They're smoking. They're pulling the wheel, doing their thing, right? So that general impression just tells you which one of those two, and it doesn't mean that one is better than the other, but which one of those two heightens your senses and says, oh, this is something we're going to have to make sure we move on quickly. But that's that general impression. It could also be, and here's a little sidebar, you know, the blind date. You show up for the date and you're just like, yay. Or I'm sure you have a very nice personality, and that's not directed at a man or woman. That's just that first impression that you have as you see your patient. So again, multiple ways of trying to give you to focus or think about this. In the airway and breathing, yes, if they're conscious, they're talking to you, as I explained, with the shortness of breath or the dyspnea, the 2 and 3 word sentences that they may be able to take. But we still got to check this, right? The respiratory rate, depth, and quality. Is there equal rise and fall of the chest? Do we need to give them oxygen? Well, if oxygen or the breathing has been affected, yes, it's a win-win. Let's make sure we give them the oxygen. If they're unconscious, the two different techniques to open up that airway, right? There's the head tilt chin lift, because the number one airway obstruction in unconscious patient, again, yes, is the tongue. If it's a suspected traumatic injury, that's where the jaw thrust comes into it. Yeah, oxygen to your patients, yes, we looked at that. Now, when you get into an unconscious patient, this kind of goes along with your other skill sheet of dropping the OPA after you've, of course, measured that. And now do you have to bag that person? But, you know, a lot of those decisions are going to be made on the tidal volume, what is the respiratory rate, depth, right? All of these things that come up and go into your critical thinking. For circulation, yes, I'm going to check for a pulse. I'm also going to make sure that there's no bleeds. That's something that goes along a little earlier when we think of trauma, because there may be that obvious sign of a life-threatening bleed. But here, think of this more of a potential secondary, I fell, scraped my arm. But anytime that circulation is spurting from an artery, that would become a life threat. If they're unconscious, yes, stick to the carotid pulse. But could you imagine someone's up and they're able to communicate with you and, hey, I'm going to check your pulse. And you start putting your fingers on the carotid, right? So the conscious patient's pulses going to be done at a radial pulse. Again, we start thinking about infants and children because it's primarily dealing specifically with adults. We get into pediatrics a little later on. Remember, there's different pulse points and assessments for infants. If I'm dealing with an infant, you know, am I going to a brachial pulse? Do I have to find a femoral pulse? But different pulses, although this does not cover all of those ages and the assessment techniques of those. Transport decision, is it a rapid transport? So who falls into that rapid transport? Is your patient unconscious? You got an airway or a breathing problem, that's one that should jump up to the top. And then we look at this obvious circulatory problems, signs of shock. Well, okay, they're pale, they're cool, they're diaphoretic, you know, whatever that case is, you throw in severe bleeding to that, it becomes a priority transport. The history taking, right? This is where ask and answer comes in, right? I can communicate with my patient. If they are unconscious, this is where we look for medical alert tags. Is there a bystander, someone who we can talk to that's going to help give us this information? Sample history, signs and symptoms, allergies, medications, pertinent history, last time they ate something, events leading up to this event, and we also want to include, is there a chance that they could be pregnant? Right, so I always include that with sample. Obviously, if I'm dealing with a 60-year-old guy, that's really not a concern. But is there a chance that your patient could be pregnant? This is where we can have, I'm going to patent this term, mnemonic overload, because now we got to go to OPCURST. OPCURST, I like to put a little I in here as well. Explain what that stands for as we move through. But onset, provocation, quality, radiation, severity, and time, right? Those are all questions that when we ask a patient experiencing one of those potential issues, that they give us a little clue to what could be going on with them, right? How long has it gone on? Is there anything that makes it better or worse? Pain is there's so many different ways to describe pain, right? So the quality, is it stabbing? Is it tearing, right? Is it a muscle ache? Is it a cramp, right? All of those are important questions to put together. And we look at the eye is just interventions. Interventions, we're starting to, even though we know what their allergies and medications are, hey, maybe they've taken something already. And so I just want to be aware of that. Obviously, documenting the allergies, the conditions, the medications. Take those medications with you, right? There's many medications that can have synergistic effects. Any box of medication you look at says, hey, don't take this with this or this with that, or if you do, this could happen. One more mnemonic for you is tacos, tobacco, alcohol, caffeine, other, or I should say over-the-counter drugs. And then we get into, and this is funny, it's sexual or street drugs. You're like, well, sexual drugs. Is it a Viagra or something that they're taking? And then any street drugs as well. And remember, since we've had this patient for a couple of minutes now, that whole thing about being non-judgmental and empathetic as you're talking to your patient is you basically have those first 5 minutes to make that impression where this person is going to now want to share with you some, who knows what they're taking. And if they don't trust you, they don't think you're serious, you're making these, quote, trite comments to them, it's going to be harder to gain that patient's trust. On the secondary assessment, again, in the secondary assessment is talked more in the skills class or that part of it, but just know we want to assess that affected body part, right? What is it that they're complaining of? Now, I know it's a respiratory issue. I'm exposed to chest. What can I look for? Are there hives? Are there any indication of some type of anaphylactic reaction? But that's getting us into the secondary assessment for your patient. If they're unconscious, well, it's something that we always have to do, but it should include the entire body, right? Because again, if you can't find what's wrong with them, it's going to make it really hard to fix that. So conscious patient, yeah, they tell me I'm good. It's, chest pain, right? I can kind of focus my assessment to that area. But if they're unconscious, we need to make sure there's nothing that we're going to miss. Let's not miss something. Physical exam, that's, again, the head to toe, that 60 to 90 second when we do a rapid trauma exam. But here, maybe I look at the person's neck and now I notice JVD. Oh, jugular venous distension is an indication with blood flow having a hard time returning to the heart. So is there anything else I can clue into? Or is there any sign and symptom? Yeah, I'm going to assess the chest and abdomen and other terms that come into this. Inspect, palpate, auscultate. So yeah, I want to see it, but if it's something I can listen to, I want to auscultate that. Is it the chest that's a problem or down to the abdominal region? I want to make sure, rule out appendicitis, all these other things that we're concerned with. When we move over to vital signs, of course, the pulse rate, quality, regularity of that, the initial blood pressure is done. And I think it's important that you know where that's actually done on your medical sheet. So, we don't want to do this up here when we're still not sure that our airway, breathing, and circulation is okay. So again, don't throw those vital signs at the very beginning because that's going to throw everything else off. The blood glucose, consider obtaining a blood glucose. Get a blood glucose. Okay, blood glucose is also considered a rule-out criteria, right? Are we somewhere between 80 and 120? Again, just because someone's at 79 on their blood sugar finger stick doesn't mean this is a hypoglycemic episode. But again, it's just an additional tool or test that we have. Remember, we have to gather all of this information up so we can then relay that to the hospital. So I always get a blood pressure, of course, but the blood glucose is something we want to think of as an always as well. Pulse ox. Pulse ox is great as long as you have that understanding that we treat the patient, not the monitor, right? What does that pulse ox show? Oh, it shows 60. Okay. start bagging that person. Well, that person's conscious, alert, and oriented ×4, right? The problem on your pulse ox is are there acrylic nails? Is there fingernail polish that's actually on? Are they cold, right? Is that more of a process of vasoconstriction? So that's why pulse oxes can be a good thing, but they can also lead you down a wrong path. Reassessment, again, is it 5 minutes? Is it 15 minutes that we're going to be assessing our patients? Critical patients get reassessed every 5 minutes. Stable patients get assessed every 15. But obviously, reassessing your interventions, make sure what you're doing is working. And if it's not working, maybe there's another plan that's developed between you and the doc as you're on telemetry saying, hey, now I need to do this or that. So, but document the changes, right? If you don't write it down, it didn't happen. The transport decision, where are they going to go? Well, again, most of these emergencies are something that you're going to be fine taking them to the closest appropriate facility. Closest appropriate facility, key term, you hear this stuff all the time. There are specialty clinics, as we think about different stroke centers, or one of the hospitals that's no longer in operation was Tucson Heart Hospital, and maybe patients want to go there. Keep in mind, patients still have the right to decide what hospital they're going to go to, but that should be a conversation. If you tell your patient, no, this one is going to be better for you, then that's where you would, encourage that they go. I'm not going to take anybody against their will. That gets back into the chapters 1, 2, and 3 on potentially kidnapping your patient. So again, it's a conversation with the patient. You are a reasonable, highly trained medical professional. I recommend you go here. That's part of that, and that's I don't want to just put it as convincing, but why it's a good idea to communicate with your patient and have that good relationship. On your seam time, medical patients may take longer than trauma, because trauma, we load up and you go. So there's additional questions that we ask. There's more of an assessment process. It may take time to gather medications, but if it's any type of critical issue, then all that goes out the window, right? That's when you're going to do that rapid transport if you do have a critical patient. This is the difference between code 3 and code 2. Code 3 is the actual lights and sirens. Code 2 is normal traffic. So which one is it? There's certain policies and procedures that each agency has for that. Something that also has to be in your gut. And if your partner's telling you, hey, patient's going south, then you light it up. And again, there's certain rules, and due regard comes into this. That's something that's actually taught pretty in-depthly in the ambulance operations class. But code 2, normal traffic. Code 3, lights and sirens. Are you going to take them ground? Are you going to take them air? So ambulances here, there's different combinations. There's 2 EMTs. Sometimes it's an EMT and a paramedic. Sometimes it's 2 paramedics. Okay. If you need to ship someone out by air or the helicopter, that's great. Why is a helicopter a good idea? Critical care paramedics as well as nurses on board can do more invasive procedures than potential BLS ground unit could do. And that's something that you've considered early on when you're thinking about additional resources. So where are they going to go? Closest appropriate facility. Wouldn't advise taking a level 1 trauma patient over to St. Mary's, right? When there's trauma centers, there's UMC, there's St. Joe's. So again, if it needs a certain destination, then that's where you need to go. The assessment principles. Now, for infectious disease, I was just going to skip this area because I don't really think that that's something that's going to come up in the near future. Sarcasm alert. So there's a couple of things that we should address and potentially change on this. And this all goes with response protocols and how things are being addressed now. Approach them like any other medical patient. You have an infectious disease. And I thought about that. Well, what do we do with all patients? We use BSI or PPE, right? Personal protective device, also something where those are the tools we utilize to create our universal precautions, right? There'll be no time where I go up and deal with a trauma patient and I don't have gloves and goggles on or anything that's squirting blood. So we're always going to be protecting ourselves. So I went back and forth with this approach like any other medical patient. You kind of, as long as you are utilizing your proper techniques, and we'll drill that into your head time and time again, make sure the scene is safe and have the appropriate PPE. As far as questions, and I think it makes good sense now to know where someone has traveled from. There's different diseases in certain regions that, could be more prevalent. So yeah, I want to know what's going on. That's information the hospital is going to want to know, because you don't want to drop off that patient, expose everyone else that's in there. So now they can, draw the appropriate room for the patient, or it may take additional time to set that up. But we don't want to bring, example is your COVID patient now, someone who's coughing and sneezing all over the place, and I don't tell the hospital about that, right? That's the example I can give you from that. Now, obviously, just focusing on the life-threatening conditions, focus on the fly that's coming around, be empathetic, right? Empathetic, right? You're just caring and kind for all of your patients. But this should go first, right? Standard precautions, universal precautions. I was going to skip this too, because epidemic and pandemic, we are too well prepared to have something like a pandemic. Oh, wait a minute. So everybody's aware of what's going on. The difference is when you start looking at the epidemic, new disease, but it's worse than they expected, right? In one specific region or area. When you get into the pandemic, now it's something that's on that global scale, right? This is what you are living through now, and some of the difficulties of getting your PPE. How are we going to get all this? How am I going to go back to that, 2 slides ago and say, oh yeah, I make sure I have my standard precautions. So whatever those decisions are, obviously just do it the safest that you can. The flu, and I found this interesting as well. Again, these are all the reports. Watch the news for 5 minutes. That's all you need to do. Where the very young, the very old, they're more susceptible to this. Patients that also have compromised immune systems. If you haven't heard that before, then again, you haven't watched any of those stories. But these are all things we're learning, and it's evolving and it's changing. But how that flu virus is actually going to be spread, nasal secretions. Your masks are going to help with that. Those aerosolized droplets that come, coughing and sneezing on, I get that from an infected person. And now what's so scary is you could potentially do that from an asymptomatic patient. So this is why it's like all of society is just using those universal precautions. So specifically with, influenza, even addressing this with the COVID-19, because you'll see there's actually been multiple types of COVID out there, but specifically with this, yeah, it's a respiratory route. So your PPE, your gloves, your eye protection, that's great. HEPA respirator, high efficiency particulate aspirators, what is it that you have? Again, the goal here, and this is great, these are slides from our 11th edition, places surgical masks on patients with suspected or confirmed respiratory diseases. Well, why? Because it'll still stop some of that. Remember, you've got that N95 or your HEPA on, so that's a good form of protection, but this is so that person who's laying on your gurney and coughing up stuff is not being spread, not only to you, but to wherever you end up bringing them into. Obviously, if we were doing clinicals and I was sending you to the hospital, your flu shots, great idea. Get your flu shot. Can't send you into a facility if you don't have your flu shot. The herpes, you got that lovely bump on your lip or other places, but virus strains, and again, this is carried by humans. The more serious illness in susceptible patients, right? Susceptible patients, more at risk for, right? Has more detrimental effects on them. But close personal contact, not something I've had with many of my patients, so feel pretty good about that. HIV, human immunodeficiency virus in here, less risk of exposure, but there still is some, right? Do you deal with patients' blood? Do you deal with patients' bodily fluids? Yeah, you do. I look down at this too, not easily transmitted in the work setting. Okay, that is a specific key to EMS personnel. I'll just say, I guess it kind of depends on the work you do, on whether or not you're higher at lower risk for HIV. The same thing goes with potential HIV patients, which same thing with your COVID patients, right? Not everyone shows those symptoms of that, right? I've heard multiple stories on this. Person, was fine. They get a routine blood test or something before surgery, and then they find out they have the virus. So obviously, in the needles, and really the needles that you're using are lancets, which should poke and come back. Sometimes there's a lancet which actually stays out about that 1/8 of an inch as you poke them, and that is a sharp, right? That goes directly in the sharp spots. But a bigger concern is, we're covering the patient's wounds, but if you have cuts on your hand, if you have, again, something that is not covered, well, think about covering that as well. Because when we do those procedures, and it could be an IV, if that's your partner that's doing that. I know there's EMTs that can do IVs, but that's not taught in this curriculum. That's a permissive skill offered by the state and the medical director. So if you've got, cut on your arm or something, you're going on shift, make sure you're covering that up as well. Not only the patient's wounds, but yours before you even start working. There is a reporting process for this. If you think that's been, you've been the subject of an exposure, make sure that you report that to the infectious control officer, right? Everybody has one. It's just policies are set in place so they can make sure you get the appropriate help if that's what you need. Hepatitis, something that's going to inflame the liver. There's no sure way to tell which hepatitis patients are contagious. Again, just like everything else we've seen, it's COVID, it's, HIV. So again, those are important things to remember. Universal or standard precautions, always at the top of the list. There's declinations that are available for the Hep B, but why wouldn't you get it? Honestly, just take a minute to think, if this has the potential and you deal with patients, why would you not want to have that protection? Meningitis is also a reportable. So it means you're obviously going to have to let the ED know, let your employer know, is this something that could be transferred to you? It all goes into documentation and protecting yourself. Now, meningitis, inflammation of the brain and the spinal cord, there's a meningeal covering of that. You either show up with a stiff neck. When you jump over here to TB, that's something that you should be familiar with, is the TB skin test, right? Just a way that we can tell, is this a positive or a negative? You're negative. Great. If you show up with that positive, then maybe you need the chest x-ray. Again, different ways that you can ensure that you're clear from this potential disease. Now, as far as dealing with those patients, respiratory TB, that is a contagious form of this. We're getting back to the N95s or the HEPA mask. Those things are required to stop the droplets, right? And these are small little droplet nuclei that can actually come out and go through some of the non-N95 or the HEPA masks. So again, it's always offering yourself the highest level of protection. But the TB patient, generally they have this cough associated with that. I don't want anyone coughing on me anyway. So notice there is a surgical mask on him, but then the providers are actually using a higher level of care. It may be y'all have a bandana on now, but whatever it is, we have to slow down or stop that potential spread. See video entitled "Cover Your Pie Hole" to know what could potentially happen. Evidently, it's time for someone to do yard work. I got landscapers out here today. So TB, absolute protection from the tuberculosis does not exist. So that means you don't have that ultimate form of protection. The getting your skin test done regularly, right? And if you do get this before you come out, this is why we encourage you to have those tests done. Look at your treatment, almost 100% effective. That's awesome. But that's early monitoring or tracking of this, or if you have that suspicion, write it down. Because if you don't write it down, you should be filling in the blank, it didn't happen. Whooping cough or pertussis, the less than 6 years of age. How do you prevent exposure? You get vaccinated. I'm not going to stand on the soapbox and talk about vaccinations, but get yourself vaccinated against any and all things that you can get yourself vaccinated for. Vaccinations are the greatest gift to the world. And some people refuse their gift. That's fine. More for me. MRSA, methicillin-resistant Staphylococcus aureus. There's certain people who are more susceptible to that. And this is kind of nasty. In a healthcare setting, MRSA is transmitted from patient to patient. So, right, I'm over here. Then I'm going to go deal with my other patient by healthcare workers' unwashed hands, right? Secondary contaminations in that. So, I have not done a video on washing your hands because I think you all know, wash your hands. And this goes back to again, I'm sorry if it's chapter 1 or 2, but you have to make sure if you can't wash your hands, what do you use in the meantime? Oh yeah, some alcohol-based gel. And then when you get to the hospital, wash your hands. So you may be starting to see that what we talked about in the early chapters is now showing up over here in 4A. Factors that increase that, antibiotics. Antibiotics. And they've been on that for a long time. Been in the hospital for a long time, give you more opportunities for people to not wash their hands when they touch patient A and come over and touch you. Or again, you yourself are actually exposed directly to an infected patient. It does give these soft tissue infections. Once I get better at this, I'd like to also throw in some pictures. You can see some of these different things or how this patient looks and some of the things they may actually respond when you're asking those sample questions. Now, this one, Middle Eastern Respiratory Syndrome, coronavirus. So, right, coronavirus, this is 8 years ago. But more importantly, no cure vaccines for this virus at present. That was 8 years ago. And it's a different, strain, if you will. And if you're paying attention, they are working on something currently. But as far as 8 years ago, they weren't able to come up with a cure vaccine for this as well. The Ebola, the outbreak in 2014, this is why some of those questions are asked of your patient. Hey, where have you traveled from? And, if it was 2014 and it's December and I've got someone who's complaining of this or that, and yeah, it's not to, put this person into this corner or to, I don't even know the word I'm looking for, but to say pick on them. It's just to find out because you need to protect yourself first, right? It's me, it's my partner, it's the patient, it's the public. And when we're up here and you're telling me you're coughing or you've got this or that going on, I want to know so I can keep myself and my partner safe. But pretty high fatality rate if that treatment is not initiated. So again, early identification, always a key. This goes on, and I alluded to this in your previous chapter, was travel medicine, the asking patients who have traveled outside the U.S., different variety of symptoms, the ill patient with a recent travel history. Again, minimum of a mask, protect yourself as we get them into the facility. Important questions. Again, right, different hotbeds pop up. And this person came, roll you back to February 1st, and you got the patient who is and they're sick and they're running nose and they're sneezing and all that nasty stuff's going all over, and they tell you, hey, I just came from this place. And oh, okay, so is that something you were exposed to? Again, it's just asking the questions so we know what could be going on. Types of food. Hey, did you have any Cobra fries or a bat sandwich? Okay, maybe this is something that's just a GI problem, or is it actually the virus? Did they drink some nasty water? And there's different bacteria that are generated from that. So in conclusion, medical patients can be challenging. When we look back at those 8 potential issues in the secondary assessment for your patient, there could be a psych issue, it could be a behavioral issue, again, and those are all things that potentially come up. The best thing you can do obviously is protect yourself. We address the airway, the breathing, circulation. Keep in mind those specific chapters, neurologic, cardiovascular, respiratory, psych, and toxicological emergencies. Those are all going to be discussed further in depth in those chapters. So I hope you enjoyed your medical overview. September 1844. Tell me on the comments why, and I'll give you 1,000,000 points extra credit if you come up with that. But 1,000,000 points extra credit to you if you can tell me why that September 18th, 1844 is an important date. And thank you.